So today we're going to talk about the complete evaluation of a difficult airway. So this topic is important on two counts. One is for theory because you need to be able to answer questions with regards to evaluating a difficult airway, and honestly, more importantly is the practical aspect, because having a difficult airway is a very common scenario in routine clinical practice, even bigger fear in clinical practice, because of which we need to sort of be able to be aware when to be worried. When we talk about evaluation of the difficult airway, we need to be able to figure out what we're going to do today. So we're going to be able to define a difficult airway, understand the importance of predicting a difficult airway, understand the approach to assess or predict a difficult airway. How do you carry out a clinical assessment of the airway? Are there other newer airway assessment techniques? We're going to go over some composite scores and mnemonics for airway management and also preparation of a difficult airway. Now, how do we define a difficult airway? Now, there are various definitions that exist. One is the conventional ASA one, which I believe is fairly easy because it talks about experience when a trained anesthesiologist experiences difficulty with mask ventilation or tracheal intubation or both. The Canadian one, which is a little more recent, is a lot more comprehensive because they talk about a mixture or isolated events of difficulty of face mask ventilation, of supraglottic airway insertion, or direct or indirect laryngoscopy, or even for that matter, difficulty in surgical airway. And that honestly is what the newest or 2022 ASA guidelines are about, that we don't restrict defining a difficult airway as something that is there only at intubation with an endotracheal tube. But we expand our understanding and say that a difficulty in the airway could be anywhere. Now, this still, mind you, does not talk about difficulty at extubation, which is also something that the newer guidelines, whether it is IDA or whether it is ASA, urge you to look at. Sorry, my presentation's got it. So, when we look at an airway, we have to understand what makes this airway difficult. First and foremost, it could be something that is a congenital an anatomical issue. It could be a pathophysiological issue, or it could be a combination. When I say anatomical issue, what do I mean? I mean could be some congenital problems. There could be a decreased mouth opening. There may be an actual mass like a CA alveolus or something like that, which is causing the difficulty. Or there may be a ranula which has come for evaluation or excision for a little baby. There could be it could be a many number of things, or there could be scarring, or there could be a history of radiation, the scarring from a burn, or there could be deformities for other reasons which make an airway difficult. Or there could be pathophysiological issues, like the patient could be pregnant, they could be at an increased risk of aspiration because they're diabetic, they're full stomach. They could be sick patients, so they have decreased reserves. There may be a risk of airway edema, or there may be a risk of air collapse of the airway on extubation, like it is with long-standing thyroid. Or it could be a combination of any number of these. Now, why do you need to predict a difficult airway? Is because of the NAP4. Now, it's important because all of you are trainees for you to remember the NAP4 audit. The NAP4 audit was undertaken in 2008, 2009. Why are we quoting statistics that are so old? Because when the national audit projects happen, every year they do an audit on a different aspect of anesthesia. Right? So the NAP4 was the audit on air. So we need to remember it for airway. It said that for 1 in every 22,000 airway interventions, they found an adverse effect. For 1 in every 1,80,000 interventions, there was death. Now, if you look at the authors of this project, or for honestly, even my personal opinion is that even one death due to any failed intervention is one death too much. So these numbers need to be taken seriously. What the audit also tells us is that the actual number of airway adverse events may be larger. Because, like even if you looked at what makes the airway difficult, because it could be such a combination of events, you'd never know if the adverse event, maybe people couldn't attribute the adverse event to the airway intervention itself. That is one. Maybe they didn't report it. So they surmise that the actual numbers may be 4 times as high. They did a root cause analysis of what they found. They found that patient factors, there was an actual difficulty because of patients in 77% of the times that there was an adverse airway event. But in 59% of these, the medical staff had seriously misjudged the difficulty of the airway, which essentially means that you have to take each and every airway seriously. How do you go about predicting a difficult airway? Now, if your airway looks anything like the pictures that I've shown you, you're lucky because it's very obviously difficult. Your trouble arises when you have a normal looking individual who becomes difficult after your laryngoscope goes in. So, this is what we are hoping to figure out through this lecture. Now, if I want to evaluate a difficult airway, what do? I need to have a systematic approach. Now, this systematic approach helps when I'm answering the exam or writing an answer or whether it is evaluating a patient, because then I know that all of my goals are marked, like all of my goals are met, all of my boxes are ticked, and which means that there is a likelihood that I have not missed anything. For that, what is the first thing I need to do? I need to take a thorough history. I need to evaluate any medical records that are available, do a clinical evaluation, get appropriate imaging and investigations as required. Now, prerequisite in all of this is when you're examining the patient, make sure it's a well lit area and the patient's face must be at your eye level so your estimations are correct. Why do we need to look for history? Because the patient could have congenital conditions like, say, Pierre Robin, Treacher Collins, Down syndrome, or Klippel-Feil. Now, I will not spend more time looking into why each of these syndromes makes the airway difficult, because we have a lot to cover with regards to actually evaluating the airway. But these are these certain syndromes, no matter how rare they are, the fact is when you see them, you know that there will be a difficulty. You could have chronic diseases like rheumatoid arthritis, ankylosing spondylosis, diabetes mellitus with limited joint mobility. So these are the diseases to watch out for when a patient comes to you with chronic diseases, particularly those that involve small joints. You need to be worried about neck mobility, about the elasticity of the tissues, which will maybe not allow you to intubate as well as you would like to have. You need to worry about recent acute respiratory tract infections because you want to know how the airway reactivity is going to be. Laryngospasm, bronchospasm through the airway intervention is obviously not a good idea. We need to be on watch for OSA because obstructive sleep apnea can be disastrous. It could have multiple consequences. We need to be able to watch out for features or history that suggests a worsening of airway pathology, such as stridor, any degree and progression of hoarseness or any voice change, dysphagia, patients patient being unable to lie flat, extra secretions that are just drooling away. So the patient is not able to handle their own secretions. Those are sort of the red flags that should tick you off and say, I need to evaluate this airway a little more carefully. We need to look at history of facial trauma, obviously, because there's going to be pain, there's going to be swelling, there's going to be trismus, which means that each one of these factors is going to make it difficult for you to manage your airway. Then we need to look at chemical or thermal injuries because those are also going to complicate your management. What do we mean by chemical injury or thermal injury? By chemical injury, we mean caustic ingestion. So you have a lot of these young patients coming to you with caustic ingestion, which means their entire airway, upper esophageal tracts are corroded with the acids, and you don't know what to do with them because all the structures look very difficult. Similarly, patients coming to you with airway burns are also very difficult to handle. Then we need to move on to our clinical evaluation. I apologize for the pictures being, inverted, but that's just the way how it fit on my slide. We'll go again in order. First and foremost, like we always do, I'm sure all of you do this. So you ask them to do a mouth opening. Now, what's a fancy way to say mouth opening? When we say mouth in the exam, we're not going to say mouth opening. We're going to say inter-incisor distance. What is our magic number? Less than 3 to 3.5 centimeters. Does that mean we will not be able to intubate? No, it does not. What it means is that you're going to have to be careful. You're going to have to, strategize as to how you want to handle this airway. We're going to do a Malampati classification, which is given on your right, which is something that you do day in, day out. MPC 3 and 4, you're going to predict difficulty. Then you're going to look at their mandible. If they have retrogradnia, that's a very small mandible, less than 9 centimeters in size as an entirety from the tragus. You're going to say it's small. Then if you find that you're going to ask them to protrude their jaw or do what is called a slux test. If they are not able to